I'm Dr. Anthony Kaveh, and this is a real-life operating room where most folks have no idea what happens to their body as they're having surgery. And I want you to know what happens to your body so that you know what to expect, so that you can be prepared. I'm going to walk you through the medications folks get in the operating room when they're having surgery. We'll talk about the breathing tubes, the ventilator like you see behind me. And I want you to ask questions about every stage of the anesthesia process so that you know what to expect. And we're going to start with the pre-medication phase, which is before you even walk into the operating room. The pre-medication refers to things that often help calm anxiety. They don't necessarily render full-on anesthesia. They're things like benzodiazepines, like what I have here, midazolam, or it's also called Versed. Sometimes we give low doses of fentanyl, what you see here. Sometimes I'll use low doses of ketamine, even low doses of propofol. These are helpful if you are having a pre-procedure, like a nerve block before your full-on surgery. Maybe you're getting an epidural, you're getting a spinal, or you're getting something that involves a needle, and we want to give you something to be a little bit more relaxed. Now, some of these medications, in particular the potent benzodiazepines like Versed, will wipe your memory, so some folks won't even know what's happening to them for their nerve block or for their spinal or epidural. Another important pre-medication is not like these medications at all. It's called famotidine or Pepcid. Sometimes I'll use a little bit of Reglan, like you can see here with the green cap, or Zofran if a patient has a particular propensity towards acid reflux or nausea, because I don't want you to be having nausea or having acid reflux when you're in the operating room. Peanut had spinal anesthesia. That is a classic example of needing or often getting a pre-medication so that that initial needle going in doesn't hurt as much. I will often use a little bit of fentanyl, maybe a little bit of Versed before doing the spinal. Very, very good questions. Oh, and here we go. Larry had Versed, not Versace. I think you mean Versed. LIDAR is asking, is propofol and midazolam 100% effective at wiping memories? Not 100%, depends on many patient factors and what your brain has seen before. So by and large, in someone who has not received these powerful medications, propofol and Versed can be very effective for that. Let's move on to what happens in the operating room to your body. And this is where things can get a little bit dangerous or a little bit more intense, if you will, because once you come into the room and you come onto the operating room table, then we have to start giving you some stronger medications so that you can begin to tolerate the surgery. Stronger medications are needed so that we can prepare your body to either be cut open or to have the breathing tube placed. So this is one type of breathing tube. You see that it's actually quite flexible, and it's even more flexible if I remove the stylet or this flexible plastic from it. This will often go in patients' mouths behind their tongue because your body needs to be so asleep to tolerate surgery that your brain goes so deep into sleep that it will forget to breathe. We abolish the breathing reflexes, or we paralyze the body so we can tolerate surgery. And if your muscles are paralyzed, you can't breathe. So we need to place a breathing tube and connect you to the ventilator like you see behind me here. This guy will breathe for you while you're asleep and will also deliver anesthesia gas through your lungs to your brain. So there's a lot of things that are going on here as you're asleep. And the first step to make that happen is to go completely into a deep, almost comatose state. That's called induction of anesthesia. We use medications like the white stuff here, propofol or ketamine, so that we can go so deep to sleep that we can then place this tool called a laryngoscope into your mouth, literally lifts up your epiglottis out of the way so that we can then place this tube just past it. So these two go into your mouth, literally like this, so that this lifts tissue out of the way, and this breathing tube can go in to the back of your mouth behind your tongue to help you breathe. Now, this is important because if you have had a sore throat, and let me know in the comments if you have, it's from this procedure typically. Couple questions coming in now for the induction phase. CJ says, I'm allergic to ketamine. What would you likely use for anxiety? I'm actually allergic to morphine and also to Versed. I would personally use a very low dose of propofol if someone had those allergies. But it, of course, depends on what your doctor wants to give you based on your past history and your other medical conditions. Sally had a sore throat. Now, we have multiple tools in surgery to help minimize sore throats. One of them is this medication here. It's always an amber type of vial called dexamethasone. It's a type of steroid that can help hasten the resolution of a sore throat. So it can't prevent the tissue injury from this going into your mouth, but it can help your body recover from it faster. I'll often give dexamethasone to patients who get a breathing tube so that we can minimize the sore throat like what Sally had. But there's more that happens. I haven't shared with you the scariest of all parts of induction of anesthesia, and I think that's the paralyzing agent. So this thing here is called succinylcholine. They usually have some sort of orange or red on there to get your attention because medications that paralyze patients can cause mayhem on your body if you don't have a doctor there to support your breathing. It's another reason why we need to have the breathing tubes and the ventilator, because if your body's paralyzed and it can't breathe, you need to have someone taking control of your body's vital functions. The paralyzing agent is often needed to place the breathing tube because the human body will tense up so much after the laryngoscope goes into the mouth that it actually precludes us and prevents us from placing the breathing tube. So we have to paralyze the body first so that all these muscles in the jaw relax, and then we place the breathing tube. So we want to make sure that you are fully asleep before we paralyze you, before we place this medication. And this is where the other complex part of induction comes in because, and this is the most complicated part of the whole anesthesia in most cases, when you give a lot of medications like propofol, your heart muscle will also become less effective at pumping. You might think, oh, why is this a big deal? Because if your heart can't pump properly, you can have a heart attack or a stroke. Now, Edie is asking here about why my jaw hurt for days after. This is a really important point because, and it all comes back to the heart. If somebody cannot tolerate the correct amount of anesthesia, they might be very tense. So instead of just giving more of this anesthesia to relax them, because you'll eventually relax all the muscles with enough propofol, but your heart muscle will also relax. That's why we need to use that paralyzing agent so that as long as we can wipe your memories with this, then paralyze you, we can place the breathing tube without having to turn your heart off and still not have you remember. So this is the math that goes through the anesthesiologist's head of how much do you have to give of every medication so you don't have someone with a hurting jaw after because you had to yank so hard in their mouth to get that breathing tube in. Elliot asks, how does anesthesia take consciousness away during this induction phase? Well, I'll answer that after I first tell you that we need to support the heart, because when you wipe consciousness, you can also wipe your body's ability to circulate blood. We have medications like what you see here, phenylephrine. This little guy we will often give during induction in patients whose hearts cannot handle anesthesia. Medications like this can help maintain your blood pressure to counteract the heart decreasing effects of anesthetics. So it's a combination of supporting your heart, wiping your muscle, wiping your consciousness, paralyzing your body. And if that wasn't enough, we actually have to give some more of that fentanyl to prevent your heart rate from spiking, because even if you're unconscious from the propofol, your body will still respond to the stimulation of placing this behind your mouth. This is one of the most stimulating things that you can do to a human body, and you will cause a heart attack or a stroke in someone potentially if they don't have a sufficient amount of opioid in their system to quiet their pain response. You got all that? So Elliot is asking, how does anesthesia take away consciousness? Short answer is that we don't know because we don't understand consciousness in modern medicine, but we know medications that can wipe memories and seem to turn off the parts of the cortex of your brain where we believe consciousness arises from. But at the end of the day, we don't always know. Malta says, why do I have such horrible reaction to nitrous oxide but tolerate ketamine so well? Both are dissociative anesthetics. To a degree, ketamine more so considered that way. But they are both completely different molecules, even if they have NMDA receptor antagonism properties. When you say horrible reaction to nitrous, I'm wondering if you are referring to the nausea, that laughing gas, which is what nitrous oxide is, can cause. I personally don't like to use laughing gas because some folks can get so nauseous from it. Very good question. So moving on to the maintenance phase of anesthesia, because we ain't done yet. You still have to have your surgery. This is all just the anesthesia preparation we've talked about. But this point gets a little bit easier. Believe it or not, once we've stabilized the human body, for most surgeries in patients who are otherwise healthy, it's a little bit more relaxed and a little bit easier to let the surgery and let the body go through the trauma of being cut open. This ventilator here actually releases anesthesia gas into your breathing tube, which goes into your lungs, which then reaches your brain because everything is connected. And you're actually just kept asleep through the surgery, by and large, through the anesthesia gas. We'll sometimes supplement what goes from the ventilator into your brain with things like additional opioids, anti-nausea medications, things that support your heart rate and blood pressure. We'll give antibiotics. We may have to transfuse blood if there's blood loss during a case. There's many other medications we give, but by and large, the mainstay of this is just keeping you in a steady state with the anesthesia until the very end. So, by the way, if you're learning something before we get to the very end, when people kick and scream and bite their doctors and all that, what we call the emergence phase of anesthesia, just to shout out that if you're learning something new, do please hit that like button, share what you've learned with others so that you know that you can ask your questions here so that you can hopefully better advocate for yourself if you are having a big procedure done. And that level of preparation and self-advocacy is so important in medicine, and most of my patients never get that. So please take advantage of that here. Charlie says, I had a tumor taken off my brainstem. What kind of anesthesia did they use on me to keep me awake and not know? Usually when we are doing very sensitive types of brain surgery where we need someone to be awake to follow certain commands, but we don't want them to be traumatized by the experience, we use a combination of opioids, like fentanyl or remifentanil, benzodiazepines like Versed, and then typically a little bit of gas. There's many different ways of doing this, but usually the remifentanil and the Versed are the mainstay of that type of surgery. Very good question. I hope that your surgery went well. And Fiona's mom, I remembered my doctor asking me questions under general. Why is that? Well, Fiona's mom, I wonder what your name is, Fiona's mom, but without knowing what kind of surgery you had, I couldn't speculate. It wouldn't be right for me to do that. And John Middleton asked a good question. How would you deal with a 15-hour surgery differently? John, this is a perfect dovetail into how patients wake up. If you have a very long surgery, John, or for anyone else out there who has had maybe spine surgery or brain surgery or heart surgery, the longer you get medications into your brain, either through that ventilator back there or through liquid anesthesia like propofol, the longer it typically takes for you to wake up, because those medications have what's called a context-sensitive half-life, meaning that they'll stick around longer to a degree based on how long they're being infused or delivered to your body. So anyways, what this means is that if someone's having a long surgery, your anesthesiologist has to begin to turn the anesthesia off maybe an hour in advance based on the pharmacodynamics of how, and pharmacokinetics of how those medications interact with your brain. So we want you to wake up smoothly. We don't want you to wake up in a terror with a breathing tube in your mouth, because this does not feel comfortable to wake up with. We want you to wake up able to breathe so we can remove the breathing tube safely, knowing that you can breathe on your own, but without you remembering when that happens. It's like a very fine balancing act, right? I mean, you tell me, comment below. Would you want to wake up with a breathing tube in your mouth? Probably not, right? So You also don't want to have the breathing tube removed before you're breathing on your own, because then you would have a stroke, right? Because you can't get oxygen to your body. So we need to use medications that gently come off to prevent the sudden terror of waking up or regaining some level of consciousness with this tube in your brain. That's where I use medications like Precedex, especially in pediatrics, or dexmedetomidine. It's one of my favorite medications. It's a very, very curiously effective medication. Where is it here? Oh, it's out of stock here. Well, look at that. It's why you check your carts before surgery, but since we're not doing surgery here today, doing a video, I didn't check. But usually in that cart, we have Precedex, which I will dose very slowly throughout a case and maybe bolus at the end of the case to help a patient wake up without this kicking, screaming, traumatic experience where they might bite my finger as I try to remove the breathing tube from their mouth. You name it, it's happened. People can yell horrific things or, sabotage themselves by ripping out their own IV or ripping out their own breathing tube. These can be very dangerous if a patient wakes up with such significant delirium that the OR staff cannot hold them down. If you've heard of this, let me know in the comments. Emergence delirium is very real, and it's more common in folks who have had PTSD because it's as if their brainstem and brain are hypersensitized and ready to pounce at the first sign of fear or first sign of loss of control. So Craft Therapy says, Jennifer, which med wipes your memory? Well, I'm not Jennifer. Well, maybe your name is Jennifer. Got it. Why did it take months to get my memory back? Benzodiazepines like Versed tend to cause amnesia or memory wiping, but they don't tend to last very long. If memory is gone for months at a time, I wonder if you maybe had the surgery cause a problem with your memory. So for example, folks who have had open brain surgery are more likely to have some damage to their brain and the memory forming parts of their brain in addition to any effects of the anesthesia. Maybe some folks with heart surgery might have had many strokes during the heart surgery, which can lead to memory loss. Usually anesthetics are not a culprit for long-term cognitive deficits. So there are some rare exceptions, especially in older folks. Very good question. How fast do you wake up after 2 hours or less of surgery? John, very good question. Depends on what the surgery was. Depends on what kind of anesthesia you received. But typically for surgeries under 2 hours, folks are pretty awake within maybe 5-10 minutes after we're out of the operating room. But there are many exceptions to that. It's a very rough number. Very good question. Honey Hush, how many surgeries would you say in a week time you see aneurysms in the aorta? Honey Hush, that's a good question. I don't do very many cardiac surgeries anymore to see these types of pathologies. Folks that work in a big center, maybe like UCSF or Stanford nearby where I work, they might be seeing these multiple times a week. By way of reference, do you think consciousness can continue outside the brain? Elliot, I don't know. I would think it's quite possible. Who knows? I suspect yes, but I don't have any scientific data to prove that. Very good question. The reason I think so is because there are too many folks that seem to have some experiences even when the brain seems to be shut off during anesthesia. So if there's something that's processing, either we are incompletely turning off consciousness, which is a very possible explanation, or else maybe something is being processed somewhere else. I don't know. It's a very good question. What am I doing after the patient is under? Watching monitors or something else? Carol, I'm watching monitors. Maybe I'm having to redose medications during that maintenance phase I mentioned to you. If they're losing blood, we need to transfuse blood. If their blood pressure drops, we need to provide medications to restore their blood pressure, make sure they don't have a stroke. If they're not producing urine, we have to figure out why is blood not reaching the kidneys, or why is the kidney not producing urine? If they are not breathing normally on the ventilator, we need to give them the right medications to tolerate the ventilator. So there's a lot of monitoring to do because you can't speak up for yourself when you're on this table here unconscious, right? We have to kind of be your eyes and ears and heart and lungs, take over everything for you, right? Very good question. And hey, by the way, if you're learning something new, please share what you have learned with your loved ones, especially if you know someone who's having surgery coming up. And thank you, Heidi, for helping with all of these questions so we can get through as many as we can. If you're learning something new as well, you can always consider joining the membership on YouTube where I can see your comments more easily. Like Susie Go, who lights up on my screen because she's a member and I can more easily answer her questions. Honey Hush, you are very, very welcome. I'm happy to answer your questions there about the aortic aneurysms. Carrie, why do we need to take underwear off for eye surgery? Well, Carrie, not all places require that. This depends maybe on protocols that might not be rooted so much in hard science. Where I've worked, I've not seen people take off their underwear for something like a cataract. So I don't know if that's what you had or maybe one of your parents had or something. It's not necessarily the standard of care, or it's not necessarily a universal requirement. Is it true that general anesthesia is like the blink of an eye, John? In many cases it is. It depends on many factors, but usually patients don't even know the surgery has happened. Very, very good question. Honey Hush's anxiety is through the roof. Honey, I hope that this is helping you better understand how much training your doctors have, how many decades they've been doing this so they can comfortably do this literally in their sleep, no pun intended, to help you be safe and comfortable through surgery. And I do want to just let you know that a couple of news stories, totally sidebar here, a couple of news stories came out recently based off one of my YouTube shorts explaining how anesthesia is like a coma. Apparently, the vast majority of patients have no idea about this. And I'm curious if you think that learning about what happens to your body is a good or bad thing, because some folks on that comment and all those news, a couple, like 3 or 4 different journalists wrote up stories on my YouTube short. A lot of them said that, oh, I was better off not knowing. So my question for you is, do you think ignorance is a bliss? Please let me know in the comments. I'm so curious to hear your perspective as the patient. How do you tell a kidney isn't producing urine? Ed, one word, catheter. Not comfortable to place, but it's important to prevent bladder distension. If you make a lot of urine and you're not peeing because the nerves to your bladder are a little bit disrupted during surgery. So we need to put a catheter in there to drain your bladder, and we measure your urine output. In the comments, I see many people saying, knowing is best. I want to learn as much as possible. I love learning about what is happening to my body. I think it's personal. Well, a lot of people here do think that this is an important part. Wow. I'm just gonna, Heidi, I don't want to get in the way of your questions, but I just see that ignorance, I want people to see these comments. Ignorance is scary because you'll do worse when something goes wrong. Agreed. So many folks here think that knowledge and preparation is better than ignorance. Wow, fantastic, guys. I'm so happy to see that so many listeners and viewers agree with the importance of knowledge. John is asking about the urinary catheter. It does not go in all surgeries. It goes in longer surgeries. It is usually placed after you're asleep. What is a turboplasty? Maybe you mean a turbinoplasty? Maybe when the turbinates are remodeled to allow for better airflow. Turboplasty is not anything I've heard of. I think you mean something related to the turbinates. Good question. And hot spots in Hades. Yes, knowledge is power. I agree. Well, Victoria is asking me about a client who has opioid withdrawal. Well, it depends if it's in the operating room or if it's in my ketamine infusion clinic. 2 different approaches. Let me know which one you were curious about. Thank you for being a member, Sally. I've had PTSD from a nerve block done for shoulder surgery. My next procedure went well because I explained it to the anesthesiologist. And if you have a history of PTSD, you need to tell your anesthesiologist so that they can modify the environment and the medications to give you the best care possible. We cannot always prevent traumatic things from happening, but we can support you so that if the traumatic event happens, which it might happen in the chaos of surgery, you are being supported throughout. That is the key. And we'll end with Eric's question, letting your doctor know your concerns is better than toughing it out. Agreed, Eric. You do not want to be on the operating room table toughing it out if you're semi-awake for surgery. I'm sure you and everyone else listening would agree. Thank you, everyone, for your comments. If you learned something new, hit that like button, share what you've learned with loved ones, and please consider joining the channel to keep up with all of my live streams. And remember that you have more power over your health than you've ever been told.